Right now, in high-end dermatology clinics all across the world, people are paying top dollar to have highly purified salmon sperm injected directly into their faces.
Yeah, it sounds completely bizarre when you say it out loud like that.
It really does. But I
Yeah.
mean, the wildest part isn't even the origin of the product, right? It's the
Yeah.
fact that it actually works.
Oh, absolutely. It's a fundamental shift in how we approach aesthetic medicine right now.
Yeah, because we are looking at a massive leap forward in cellular repair here. It's a treatment that goes far beyond just, plumping up a wrinkle with a dermal filler. We're talking about polynucleotides.
Right. Instead of just adding inert volume to the skin,
Hmm.
we're introducing a biological catalyst.
Upcycled DNA, basically, specifically extracted from the milt or the sperm of salmon and trout. And the clinical data on this is just fascinating for you listening because it's not just some cosmetic glow up.
No, not at all. It actively stimulates collagen, it reduces inflammation,
That
and
restores elasticity at a cellular level. But our mission for today's deep dive isn't just to marvel at all the successes.
right, because there's always a catch.
Exactly. We are diving into a stack of clinical sources to examine a very specific medical curveball. We want to explore what happens when the body decides it absolutely hates what you just injected into it.
Which brings us to the complexities of acute, localized type 4 delayed hypersensitivity reactions.
Okay, let's unpack this. Because the nuance here is what makes this so critical for anyone stepping into a clinic.
Yeah, it's a vital distinction.
Because the severe reactions we see, they aren't actually a rejection of the salmon DNA itself, are they?
No, they're really not. The body's usually fighting the preservatives or the gel excipients that are used to deliver that DNA.
Right. And to understand how doctors handle that complication, we really have to look at the cellular environment first. I know the manufacturing process for these polynucleotides is like incredibly rigorous.
Oh, it has to be.
Yeah.
The purification is the entire foundation of the treatment's safety profile, really.
Yeah.
The raw material undergoes this whole sequence of ultrafiltration, thermal sterilization, and deproteinization.
And that last step is the biological key, right? The deproteinization.
Exactly. Because the immune system is hypervigilant when it comes to foreign proteins.
Mm.
If you think about a classic severe fish allergy,
Like when someone goes into anaphylaxis from eating salmon.
right, the trigger there isn't the fish's DNA. The trigger is typically a specific muscle protein called parvalbumin.
Okay, so by stripping away the parvalbumin and, all the other proteins, you're removing the chemical flags that scream foreign fish to our immune cells,
Precisely. You are just left with a bare DNA structure.
which is pretty incredible.
And from a structural standpoint, salmon DNA is over 95% identical to human DNA.
Wow, over 95%.
Yeah. So when that highly purified chain of nucleotides enters the extracellular matrix of your skin, your immune system just doesn't mount an immediate defense.
Because the architecture of the molecule is deeply familiar to it.
Exactly. True rejection of pharmaceutical-grade polynucleotides is exceptionally rare.
And it actually goes beyond just tolerating it, right? Because the sources detail how these polynucleotides actively communicate with the tissue.
They do, specifically by binding to adenosine A2A receptors.
Right, and I've read about A2A receptors in the context of the body's natural stress response. Like they usually activate when a cell is exhausted or damaged.
That's right.
But how does foreign DNA trigger that exact same pathway?
Well, it really comes down to the degradation process. As the enzymes in your skin slowly break down these injected polynucleotide chains, they release free nucleotides and nucleosides.
Including adenosine.
Yes, including adenosine.
Mm.
And in human biology, adenosine is a byproduct of cellular energy consumption.
Okay, so when a tissue is under severe stress or experiencing microtrauma from a needle,
The adenosine levels naturally spike, and the A2A receptors sense this spike and interpret it as a signal that the local cells are exhausted.
so the receptor basically flips a switch to stop the collateral damage. It tells the immune system to stand down.
Powerfully. It powerfully downregulates pro-inflammatory cytokines. And at the same time, it scavenges free radicals and protects vulnerable mucosal cells against oxidative stress.
That's amazing. So by injecting these polynucleotides, we are essentially flooding the zone with a biological signal that commands the tissue to calm down.
To halt inflammation
Yeah.
and begin the repair phase, yes.
That makes perfect sense for the pure DNA. But here's the plot twist for you listening. The syringe a practitioner picks up isn't just filled with pure floating strands of DNA.
No, it's a formulated gel.
Right, because to make the product stable on a shelf and actually injectable through a tiny needle,
And sometimes less painful for the patient.
yeah, manufacturers have to add other ingredients.
We are dealing with excipients here. These are the carrier substances that give the gel its viscosity. We're also dealing with preservatives.
And in certain formulations, like Regerin HB, for instance, you'll find added lidocaine to manage the sting of the injection.
Exactly. So we have this incredibly biocompatible, calming DNA mixed together with chemical passengers.
Right. So think of your immune system as a strict club bouncer. The purified salmon DNA walks up to the velvet rope, gets VIP access because it looks familiar, and immediately starts calming the crowd down.
I like that analogy.
But the synthetic gel excipient, that's the sketchy +1.
Right.
So the bouncer lets them in initially because they're standing next to the VIP. But a few days later, the bouncer looks closer, realizes the +1 absolutely does not belong in the club, and starts a massive brawl.
That captures the timeline perfectly, actually. Because when an adverse reaction happens, it is almost never a type 1 immediate anaphylactic response to the DNA.
It's the delayed response.
Yes, the true culprit is a type 4 delayed hypersensitivity reaction,
Yeah.
targeting those specific excipients or preservatives.
I want to challenge this from a purely clinical perspective, though.
Sure.
A patient comes in for a polynucleotide treatment, which means they're getting poked dozens of times in the face with a needle.
Right, there's mechanical trauma.
Yeah, the skin is going to be red, it's going to swell, it might bruise. So if the immune bouncer is throwing a delayed punch, how does a dermatologist tell the difference between a true type 4 allergic reaction and just the standard expected trauma of getting stabbed with a needle?
It's a great question. The differential diagnosis relies heavily on the temporal progression, the timeline, and the specific physical presentation.
Okay, so what does normal look like?
A normal response to the microtrauma of a needle involves mild erythema, localized swelling, and perhaps minor ecchymosis or bruising.
The standard party noise of an aesthetic procedure, basically?
Exactly. But that standard response is self-limiting. It peaks quickly and naturally subsides within 24 to 72 hours.
Right, so by day 3 or 4, the tissue should be normalizing.
It should be. But a type 4 delayed hypersensitivity reaction, which we often see categorized as a late inflammatory reaction, or LIR, it ignores that timeline entirely.
It presents days or sometimes weeks after the patient thought they were fully healed.
The clinical picture changes dramatically then. You are no longer looking at generalized puffiness.
What are you looking at?
The patient develops persistent, firm nodules under the skin. These are granulomas. The swelling is prolonged, and the erythema refuses to fade.
Because the body has recognized the excipient as a persistent foreign threat and is actively trying to wall it off from the surrounding healthy tissue.
Exactly. It's a targeted barricade.
Which brings up some incredible histological research highlighted in our sources, specifically the studies conducted by Michaels and Lowe.
Ah, yes. The histology is fascinating.
Because they didn't just look at the lumps, right? They actually took tissue samples of these delayed filler reactions and put them under a microscope to see the battlefield.
They did. And what they observed was a textbook foreign body response.
I imagine if the body is building a wall around a foreign substance, you'd see a massive gathering of immune cells.
You do. The histological slides were swarming with lymphocytes and plasma cells, which are really the orchestrators of a targeted immune attack. But most notably, they found foreign body giant cells.
Right, which are basically macrophages, the immune system's Pac-Man, essentially, that realize the invader is too large for one cell to eat.
So they joined forces.
Yeah. They literally fuse their cell membranes together to create a massive multinucleated supercell just to engulf the excipient.
It was a highly aggressive, localized response. It's intense.
It sounds intense.
But, the defining characteristic of the Michaels and Lowe findings wasn't just what was present, it was what was notably absent.
Oh, what was missing?
The samples completely lacked eosinophils.
Eosinophils being the white blood cells that usually flood the zone during a classic immediate allergic reaction, right? Like the type 1 response that causes sudden hives or anaphylaxis.
Exactly. The biological mechanism of a type 1 reaction is driven by a massive, immediate histamine release.
Which summons eosinophils to the site within minutes.
Yes. But a type 4 reaction is T-cell mediated. It takes time for the T cells to recognize the antigen, become sensitized, multiply, and then recruit those macrophages to form giant cells.
Oh, I see.
So the complete absence of eosinophils in these granulomas biologically confirms we are looking at a delayed response to the chemical excipient, not a sudden rejection of the biological DNA.
That is a crucial distinction. So, if you're a clinician staring at a patient with a firm, persistent lump 3 weeks after a treatment.
You know you are dealing with a localized immune brawl caused by the preservative.
Right. So the big question is, how do you dismantle that fortress without permanently damaging the patient's face?
Well, the intervention protocols are structured as an escalation of force. It really depends on the severity and the chronicity of the granuloma.
Let's start at the bottom of the ladder then. Say a patient comes in 10 days post-treatment.
Okay.
They don't have hard fibrotic nodules yet, but they have stubborn, prolonged swelling and localized redness that clearly isn't just normal healing.
Right, so for mild non-nodular presentations like that, the first line of defense is pharmaceutical de-escalation. Clinicians utilize oral antihistamines. They specifically cite second-generation H1 receptor antagonists, like cetirizine or fexofenadine.
Okay, so standard allergy meds.
Yes, and they will combine this with non-steroidal anti-inflammatory drugs, or NSAIDs, and advise the continuous application of cool compresses.
You're essentially telling the bouncer to take a breather with some over-the-counter backup.
Basically, yes. You suppress the systemic inflammatory cascade before it can consolidate into a hardened lump.
But what if it's too late for that? What if the giant cells have already built their wall and the patient has a true localized granuloma?
Yeah, that's trickier.
Because an oral antihistamine isn't going to penetrate and dissolve a firm nodule, right?
No, it won't. It requires a direct, localized strike. This is where intralesional corticosteroid injections become the standard of care.
So injecting the steroid directly into the core of the immune brawl.
Exactly. Clinicians highly favor triamcinolone for this, typically at a specific concentration of 3 milligrams per milliliter.
And how does that break up the nodule?
Well, corticosteroids work by profoundly inhibiting the production of inflammatory cytokines. They basically force those lymphocytes and macrophages to retreat. And by injecting it intralesionally, you deliver a concentrated dose directly to the hyperactive cells without causing widespread systemic side effects.
It's a targeted EMP to shut down the local immune communication.
That's a great way to put it.
But our sources detail a scenario where even a localized steroid isn't enough.
Yeah, for the really tough cases.
Right, for incredibly stubborn fibrotic nodules, the ones that have basically turned into thick scar tissue. The clinical playbook brings in a heavy hitter called 5-FU.
Yes, 5-fluorouracil.
And I've read about 5-fluorouracil in oncology. It's a potent anti-metabolic chemotherapy drug.
It is.
So seeing it used for a cosmetic complication, it seems like using a sledgehammer for a finishing nail. How does a cytostatic drug fit into this protocol?
It sounds really aggressive, I know. But the pharmacology of 5-FU makes it uniquely suited for this exact problem when it's used in microscopic, highly diluted doses.
How?
As an antimetabolite, 5-FU acts as an imposter. It structurally mimics uracil, which is a fundamental building block of RNA and DNA.
Oh, wow. So when a cell tries to divide and replicate, it accidentally grabs the 5-FU instead of uracil.
Exactly, and the whole genetic replication process crashes, forcing the cell to self-destruct.
But wouldn't that damage the patient's normal skin cells too?
Well, the brilliance of using it for a granuloma lies in its selectivity. In healthy human tissue, normal fibroblasts, the cells maintaining your baseline skin structure, they replicate very slowly.
Okay.
They aren't eagerly pulling in building blocks. Therefore, a microdose of 5-FU barely affects them.
But inside that granuloma, you have altered fibroblasts and immune cells that are hyperactive.
Yes. They are frantically building scar tissue, replicating constantly, which means they greedily absorb the 5-FU and subsequently shut down.
That is so clever.
It drastically reduces collagen formation, specifically in the altered fibroblasts, flattening the fibrotic scar tissue from the inside out without causing necrosis in the surrounding healthy skin.
So how is it actually administered?
A clinician will typically compound a minute amount, around 50 milligrams of 5-FU, blended with lidocaine, or a very low-dose triamcinolone to mitigate the irritation.
And just inject it directly into the nodule over a series of sessions.
Exactly.
It's a fascinating biological workaround. You have antihistamines for the early stages, targeted steroids to break the immune communication, and selective antimetabolites to dissolve stubborn scar tissue.
The toolkit is robust, for sure.
It is. But Buried in these clinical guidelines is a massive glaring trap that practitioners can easily fall into if they misinterpret the biochemistry of what they've injected.
Ah, yes, the hyaluronidase misconception.
We absolutely have to talk about
It
this
is a critical point of failure in complication management.
because for the past 2 decades, the dominant injectable in aesthetic clinics has been the hyaluronic acid or HA dermal filler.
Right, the standard gel used to build cheekbones or volumize lips.
And because HA fillers are so ubiquitous, clinicians have developed this automatic reflex for complications, right?
They really have. If an HA filler creates a lump, migrates, or heaven forbid, occludes a blood vessel, the practitioner immediately reaches for an enzyme called hyaluronidase.
The magic eraser. You inject the enzyme, it eats the filler, and the lump vanishes within hours.
Exactly. But the mechanism is highly specific. Hyaluronidase is an enzyme that exclusively hydrolyzes the beta-1,4 glycosidic linkages found in hyaluronic acid polymers.
So it effectively snips the chemical bonds holding the HA sugar chains together.
Right. But the danger arises when a practitioner sees a delayed nodule from a polynucleotide treatment and out of pure muscle memory or panic, injects hyaluronidase into it.
It's like pouring bleach on a grease fire.
It really is.
You're using a powerful chemical, but it is the completely wrong solvent for the material you are trying to break down.
And the result is biologically useless. Polynucleotides are chains of nucleic acids held together by phosphodiester bonds, not beta-1,4 glycosidic linkages.
So the hyaluronidase literally has nothing to snip.
Nothing. Hyaluronidase cannot recognize or cleave a phosphodiester bond. Flooding a pure polynucleotide granuloma with hyaluronidase will not dissolve the lump.
It just sits there.
Worse, it will only introduce yet another foreign enzyme into an already enraged, hyperactive immune environment, potentially exacerbating the inflammation.
Wow. There is a vital caveat in the sources, though, right?
Yes.
If a practitioner is using a specifically blended product, meaning the manufacturer intentionally mixed the salmon DNA together with a traditional hyaluronic acid filler, then injecting hyaluronidase might degrade the HA portion of that specific compound.
That's true. But for pure polynucleotide gels, it just proves why an intimate understanding of molecular biology is non-negotiable for anyone holding a syringe.
You cannot treat a nucleic acid complication with a polysaccharide solution.
The structural chemistry simply doesn't align.
Let's pull all these threads together for you listening. Polynucleotides represent a staggering advancement in regenerative medicine.
They really do.
Using upcycled, hyperpurified DNA to hijack your cellular stress receptors and command your tissue to repair itself, I mean, that is science fiction turned reality.
And the DNA itself, due to its evolutionary conservation and 95% match to human genetics, is profoundly biocompatible.
Right. The complications almost entirely stem from the delivery vehicle.
The excipients, the synthetic gels, the preservatives acting as the chemical plus ones.
Those are the antigens triggering the type 4 delayed hypersensitivity reaction.
Exactly. But as we've seen, this isn't an unsolvable crisis.
Not at all. Armed with a deep understanding of the diagnostic timeline, recognizing that a nodule forming 3 weeks out is an immune barricade, not normal swelling conditions have precise protocols.
They can deploy targeted corticosteroids to break the immune signaling, or utilize the selective disruption of microdosed 5-FU to dismantle stubborn scar tissue.
Provided they don't fall into the hyaluronidase trap, of course.
Right, provided they avoid that trap. But if we look at the broader implications of these guidelines, they all point toward prevention.
Because the single most effective way to manage a complication is to predict it before the primary treatment even begins.
Which underscores the necessity of rigorous pretreatment screening.
And I would assume that goes beyond just asking if they have a seafood allergy.
Oh, absolutely.
Even though the parvalbumin is removed, someone with a hyperactive immune system might still be a risk?
A detailed medical history is just the baseline. We need to identify underlying autoimmune conditions or histories of delayed hypersensitivities to cosmetics.
But for patients who present a higher risk profile, the clinical sources actually advocate for a physical preventative measure, right?
Yes. The intradermal test spot.
Is that similar to the patch testing an allergist would do on your back?
The concept is similar, yeah, but the delivery is deeper. A clinician will inject 3 to 4 international units of the exact polynucleotide gel superficially into the volar forearm, the inner arm.
Why the arm and not the face?
The volar forearm provides clear, thin skin that is easy to monitor and, frankly, far less cosmetically sensitive if a reaction does occur.
Makes sense.
Once injected, the clinician observes the site for 20 minutes to rule out any immediate wheal and flare type 1 responses.
And then what?
Then, the patient is instructed to monitor the site for up to 48 hours, looking for any delayed erythema, induration, or nodule formation.
You are essentially giving the immune bouncer a tiny, controlled preview of the guest list.
Exactly.
If the bouncer throws a punch on the forearm, you know definitively not to inject that specific gel into the patient's face.
It is a low-risk, highly effective diagnostic tool that respects the biological complexity of the treatment.
That concept of biological prediction actually leads me to a final thought I want to leave you with today.
Okay.
We've spent this entire deep dive looking at how clinicians react when the immune system violently rejects a tiny chemical excipient, and we are currently relying on physical test spots and waiting to see if a lump forms.
Right.
But what if the future of aesthetic medicine isn't just about formulating pure DNA gels?
Are you suggesting we bypass the physical testing entirely?
Think about the trajectory of personalized medicine. What if the real frontier is predictive genetic patch testing? Imagine a world, maybe just a few years from now, where before a needle ever touches your skin, a clinician takes a simple swab from your cheek.
Oh, wow.
They run it through a rapid genomic sequencer to map your immune system's exact inflammatory triggers and human leukocyte antigen profiles.
You wouldn't need to provoke the tissue to see a reaction at all. The sequence would highlight the sensitivities computationally.
Exactly. The clinician wouldn't have to guess or wait for a granuloma to form. They would know mathematically that your specific biology will aggressively reject the preservative in brand A, but perfectly tolerate the excipient in brand B.
Applying true precision medicine to dermatology.
It would completely eliminate the trial and error phase of aesthetic hypersensitivity.
It would shift the entire paradigm from reactive complication management to absolute preventative customization.
The bouncer wouldn't have to start a brawl because we'd already have the biological guest list perfectly curated to your exact genetic code.
That is an incredible thought.
It's something to mull over as the science of cellular regeneration continues to merge with the science of genetic mapping. Thank you for joining us on this deep dive. Keep questioning the science behind the surface, and we will see you next time.